A very good evening to all of you. On behalf of EFI, I'm Dr. Vimibindra. Welcome you all to our webinar for tips and tricks in endometriosis ultrasound. And we have a wonderful speaker from Australia. Alison, are you online?
Yes, I'm here.
Hi, Alison. So good to see you.
Thank you. It's good to see you too.
Let me introduce Alison. She is a well-established clinical sonographer specializing in obstetrics and gynecology with key interest in complex gynecology and endometriosis scans from Adelaide, Australia. She's a world-leading expert in the utility of transvaginal ultrasound for the diagnosis of endometriosis. She has been invited to numerous international conferences to speak on this topic, including the World Congress of Endometriosis, World Conference, Asia Pacific Initiative Reproduction Congress, and World Congress on Ultrasound by WFUMB. And I happened to meet her in World Endometriosis Congress last year, and I was amazed with her sonography skills. That's why we are here together today. And she is currently the president of Australian Society for Ultrasound in Medicine and has served on the ASM Board of Directors for past 5 years. She is an associate editor for the Journal of Medical Imaging and Radiation Sciences and a peer reviewer for multiple journals. In 2022, she was awarded a fellowship to the Australasian Sonographers Association. Welcome to our webinar, and everybody is eagerly waiting to hear you. And I'll also introduce you to Dr. Raju Giradi, who is here. He is a sonographer from Raichur. Dr. Raju, are you online?
Yes, ma'am.
Yes, so he has also joined us. And we also have Dr. Shinjini Pandey. She is the endometriosis excision surgeon based in Mumbai. Dr. Shinjini, are you there?
Yes, Mimi, thank you. Looking forward to Alison's talk and really hoping to learn a lot from it.
Welcome to the webinar, Shinjini.
Yes.
Dr. Madhavi, have you joined with us? You are there? Yeah. Dr. Madhavi is a sonologist and radiologist, and we work together as a team. So this is for Alison. I'm just introducing Dr. Madhavi. And I would give you the share screen option. Please share your screen and start. You can share your screen, Alison.
Thank you.
You can share your screen.
Excellent. Excellent. Can you see my slides? Okay. Can you see that?
Yes. Yes, you can see that.
Do you have the presenter view or the normal view?
We have a, you have to convert it to slideshow.
Right. Thank you, Vinny, for inviting.
Just 1 second, Alison. Just announce. Whoever is not mute, I will remove them from the webinar.
I'm scanning for is most of my clinical work these days due to demands that we encounter. So I'm very excited to be talking through this tonight. So a little bit about me. My background is I've been trained to do a bit of everything in ultrasound, but I specialise in obstetrics and gynecology, and from that have subspecialised further into advanced gynecology and endometriosis. I completed a master's by research a few years ago looking at endometriosis ultrasound, and I'm doing a PhD at the moment. I'll talk about the utility of diagnosing versus mapping for surgery, the idea consensus, and we'll go through the ending classifications as well. And I've got some tips and tricks sort of spread throughout as to how we can implement endo scanning into practice. And then if we've got some time, I've got some cases at the end. So in terms of what an endometriosis scan looks like, I think historically we did pelvic ultrasounds where we focused very heavily on looking at just the uterus and the ovaries. And we know that obviously endometriosis occurs outside of the uterus and it can affect the ovaries, but we're missing most of the areas that are going to be affected throughout if we don't go and look there. So an endometriosis scan is really about assessing the structures beyond just the uterus and ovaries through the anterior and posterior compartments to really get in and have a good close look at the areas where nodules of endometriosis will form. And we know from literature that for detecting deep endometriosis, ultrasound has quite a good sensitivity and specificity. It's very helpful for the utility of endometriomas, but it's not so helpful yet for the utility of superficial disease, although there's a lot of work happening in that space. When I scan for endometriosis, I think of doing it for one of two reasons. And so we either have a question of somebody presenting with symptoms and wanting to answer that question of, do they have endometriosis? Or we use it for people for whom we know have endometriosis or we suspect have endometriosis and are going on to surgical management. And we use it to try and map and plan the surgery. So from the point of view of the diagnostic argument,
Alison, can you hear me? Alison, we can't hear you. Alison.
Brilliant. Can you hear me again? Excellent. Apologies for that. And for the diagnostic algorithm of endometriosis, the investigation of infertility is extremely important, and endometriosis often plays a significant role in people with unexplained infertility. So having ultrasound diagnosis as an option from the fertility pathway is really helpful. When it comes to surgical management, of course, triage to the correct teams is really important in particularly severe cases, and patient counselling and informed consent is very important, particularly if there's going to be some quite invasive or risky procedures that people are going to need to make choices about. Having the information before surgery so that people can really consider that and make an informed choice is important. And we know that with a good quality ultrasound, if we can detect severe cases before surgery, then we're much less likely to have an incidence of an abandoned or an incomplete surgery. At this stage, there isn't any convincing evidence that we should be using periodic ultrasounds to monitor endometriosis, which is being managed conservatively or medically, but that may change in the future. So moving along to the IDEA consensus, and the IDEA consensus statement was published in 2016 by a group of experts in ultrasound and endometriosis from around the world. And this was really the first publication that outlined a sort of systematic guideline, I suppose, on how we should approach an endometriosis scan. And it's a free to download paper. It's worth having a look at, particularly if you're trying to scan yourself. And it really maps out exactly how we should be doing scans, how we should be describing disease. And it's got some really good graphics and schematics of explaining where disease sort of occurs. The IDEA consensus suggests that we use a systematic approach to perform the scans, which breaks down into 4 steps. So we start with an assessment of the uterus and ovaries. We then move on to soft markers, looking at site-specific tenderness and mobility of the ovaries. The third step is to look at the uterine sliding sign to detect patch of Douglas obliteration. And the fourth step is to look for nodules of endometriosis within the anterior and posterior compartments. And it really sort of breaks it down in a similar way to the systematic way, I suppose, in which surgery for endometriosis is approached to make sure that inspections are very thorough and disease is not overlooked. The ultrasound is sort of done in the same kind of systematic way. This is one of the pictorials they have in that paper. So as I said, it's well worth downloading just to look at the pictures, and it really clearly explains where nodules occur and how they look sonographically. Most people are accustomed with the American Society of Reproductive Medicine classification system. And while this is helpful, I suppose, from a sort of surgical point of view to stage disease, it doesn't translate very well into ultrasound. Because of that, there's been a little bit of work that's happened to try and get classification systems that work a little bit better with ultrasound. And there's the UBES system, which has come out of Australia, which is not too bad. But the enzyme classification system in 2020 was updated, I suppose, to try and bridge that gap between the non-invasive diagnosis with ultrasound and the surgical descriptors, so that the one system can be used for both. Again, it's another free download, and it's a good read if you haven't had a look at it. So basically, the enzyme classifications give us a bit of an alphabet soup, but it's quite straightforward to follow, where you have letters and then a number basically assigned based on how big the lesion is. So this translates very easily to ultrasound, particularly when we look at the deep endometriosis classifications, because it's very easy to measure disease and to see how big a nodule is and think of severity by size. And it's quite easy to map out your disease using this classification system on ultrasound. And you can see it marries up quite nicely with the idea consensus statement when you think about mapping disease to the same locations. So some tips and tricks to mastering scans. So number one is you need to know the anatomy, and that's I understand most people here tonight are surgeons, and surgeons generally have a very exquisite knowledge of anatomy, which gives you a real head start on scanning if you're wanting to scan yourself. The thing with ultrasound is you then have to learn how the anatomy all looks sonographically. And one of the challenges, I think, with ultrasound is really understanding the spatial awareness, because we're looking at things in a different way to how you might be used to looking at things surgically. So things will be upside down and back to front. And you really need to get your head around where the anatomy is and how you're moving it around with the ultrasound probe as well. Luckily, anatomy is something that can be learnt quite easily. So that's something that we can just learn from books and from doing. When we have a good understanding of the anatomy sonographically as well, it's very helpful to take note of the real subtle changes that sometimes occur that tell us that something is wrong. So in this case here, this is an anteverted uterus, and we can see that there is just a very slight retroflexion of the endometrium at the fundus. And that is because, and this is quite common with endometriosis, we get some disease down here at the level of the torus uterine that causes the fundus of the uterus to start to adhere to the back of the cervix or the posterior vaginal fornix, and it causes that slight retroflexion. This is another example. This is a little bit more extreme, this one, and this is what we term the ear sign in the idea consensus here. And this is a bit of a red flag that endometriosis is present and really can kind of give you a bit of a clue that you should go and look for, particularly in that area. Again, on the anatomy, this is just a picture of an ovary down here, but sonographically, when somebody's lying on their back, the ovary should typically just sit lateral to the fundus of the uterus. If we have ovaries that are sitting down in the pouch of Douglas when we put the probe in, that is another red flag that there could be something going on that's causing adhesion of the ovary down in the posterior compartment. So it's another good red flag that we should go and look for endometriosis down there. My tip number 2 is to know the technique. And the technique is probably the hardest bit, because that's something you really just get by doing. It's like any technique. It's like performing a surgery. You just get better at it the more you do it. But there's a couple of techniques in particular that I think are quite important. And I wanted to particularly discuss the sliding sign, assessing the uterosacral ligaments, and looking at the rectosigmoid colon. To do a whole endoscan and explain each step of that would take several hours probably. So I thought I would just focus on these ones because I think these are the most important. So to understand the sliding sign, it's important to think of surgery, and obviously at laparoscopy with a pneumoperitoneum, you get this absolutely exquisite view of the pouch of Douglas. Whereas on ultrasound, we can't inflate the abdomen, we can't move things, pull the uterus forward and whatnot. So we see the pouch of Douglas as this sort of potential space down in here when we put the probe in. So basically, though, if we think of wanting to see this line of sight that we're going to see at surgery, it'll look something like this on ultrasound when everything is just smooshed together without the presence of the gas in the abdomen. But by basically just using the transvaginal probe from the anterior vaginal fornix and placing a little bit of pressure on, we can see that the rectum here starts to slide away from the back of the uterus. So this is the sliding sign, and this demonstration here is a positive sliding sign, which means the pouch of Douglas is not obliterated. And this very simple technique, I mean, as long as you can find the uterus, you can probably perform the sliding sign, can in a few seconds really tell us that if we take this person to theatre, we're going to be able to actually open up the pouch of Douglas and inspect properly. So extremely valuable information for a very simple technique, really, if we're looking at surgical planning for this person. Now, by contrast, if the pouch of Douglas is obliterated and we have something that looks terrible like this, we can do that same thing where we have that same line of sight through the sort of mid-sagittal section of pressure with the transvaginal probe, we can see in this case here that the rectum is not moving away from the posterior uterus. So in this case, the pouch of Douglas is obliterated, and we can see even there's an underlying rectal nodule, which is quite often associated with an obliterated pouch. So again, with that really simple technique of just finding the mid-sagittal uterus and applying a little bit of pressure to try and watch the bowel slide, we can really detect with this scan that we're going to be faced with something that's quite difficult to manage if we're looking at surgical planning, and then that surgery can be planned adequately to allow enough time in theatre to make sure that the correct team are doing the procedure, etc. If the uterus is retroverted, the technique is slightly different. And again, this is where that spatial awareness of sonographic anatomy comes in, because the uterus has flopped into the pouch of Douglas now. So we're basically trying to have a look at this space here. So this time we have the probe in the posterior vaginal fornix, and we use a little bit of pressure here and we push the rectum away from the fundus of the uterus. So we see that this is all moving quite nicely. So that's a positive sliding sign. The pouch of Douglas is not obliterated. And similarly, when the pouch of Douglas is obliterated with a retroverted uterus with that same technique, pushing from the posterior fornix, we can see that in this case, there is rectum that is pulled onto the back of the uterus, and that pouch of Douglas is obliterated. One of the limitations of the sliding sign with a retroverted uterus is that it doesn't give us information about this lower part of the pouch of Douglas between the vaginal walls and the posterior uterus, which is quite often affected by endometriosis. So Matthew Leonardi's group in Canada have proposed this triangle sign as a way to overcome that limitation. This has just been proposed. It hasn't been tested yet, so we don't know what the diagnostic accuracy is. But basically what they suggest is that by using a little bit of probe pressure, basically pushing the probe in and out, we can try to fill this space in here with a little bit of fluid and make this triangle. So it looks something like this when we do it. We have to move the probe in and out. So again, very straightforward, just in, out, and then this space will fill with a little bit of fluid. The fluid does tend to come and go quite quickly, so you have to have your eye in for it, but it is quite straightforward, and if you test it to the left and test it to the right, you should be able to get a good idea of what's happening in that section of the pouch of Douglas. So moving on to the uterosacral ligaments. The uterosacral ligaments, I think, are probably one of the most important parts of learning to scan for endometriosis, particularly if you're wanting to look at that diagnosis of endometriosis algorithm. And that is because it's the area we're most likely to see disease on ultrasound. Unfortunately, it's also probably one of the hardest parts of the ultrasound because, again, unlike when we look laparoscopically, where you get a beautiful visualization of the uterosacral ligaments, on ultrasound, it's very hard to see the uterosacral ligaments, and that's for a few reasons, partly because they're very small, partly because of how they sit. But once you, again, start practicing and doing it, it does become something that is very achievable. So again, you need to start by really thinking about the spatial awareness of the pelvis. And I always start with this sort of mid-sagittal view of the uterus, because it's always very, very easy to get. Most people, even if they're not that confident with ultrasound, can usually find a uterus and get that mid-sagittal view. So this is looking at the cervix here of an anteverted uterus. In the screen is the caudal end, this is the cranial end. And it's important to then map out carefully the anatomy that we're looking at. So this is all vaginal vault basically here up to the posterior vaginal fornix. And the torus uterinus will be about this level, I suppose, on the ultrasound typically. So once we sort of have those landmarks in our head, what we then want to do is put the probe into the posterior vaginal fornix. So from this sort of anterior view of the cervix, we just angle back a little bit, push into the vaginal vault until the probe is right in the posterior vaginal fornix. And then we should end up with a view that looks a little bit like this, where we see the hypoechoic vaginal wall, we see the bright echogenic peritoneal surface, and we start to see this vaginal wall sort of thicken out a little bit as we come into the cervix, and then we can see rectum, small bowel, and a few other structures behind. From that position, what we then do is we move the probe out to the side. So we move it sort of pointing towards the patient's shoulder and rotate the probe about 30 to 45 degrees. When we do that, we should be in the long plane of the uterosacral ligaments, and you might be able to see something that looks a bit like this. Now, this is a particularly nice uterosacral ligament, and it's surrounded by quite a lot of fluid. So this is a sort of teaching case, because this really nicely shows the anatomy where if we're on that sort of oblique position out to the side, we should see the insertion up around the level of the torus uterinus. So that will be around here. And then the ligament will string out towards the sacrum and get thicker as it moves back usually. Now, if there is no fluid present in the pelvis, which there sometimes won't be, the uterosacral ligament will be pushed up against the peritoneal surface. And if we're pushing into the posterior vaginal fornix with a bit of pressure, we'll be stretching it quite a lot. And it will look something like this. So it will still look nice and thin at the insertion behind the cervix, and it will then get thicker as it comes out and look like a fairly uniform white band. And within that, we should be able to see nodules and things quite readily, so long as we can locate that ligament. Now, this is just an example of that same ligament with the fluid here, and you can see just the change in anatomy. When we just push up against the peritoneal surface, it just shows that anatomy really quite nicely there, where there's that little bit of fluid between the peritoneal surface and the uterosacral ligament. But again, you can just appreciate that anatomy quite nicely there. Now, unfortunately, they don't all look like that. Sometimes they'll be quite thin and quite wispy, and they can be very difficult to see. So again, this is another example where there's a little bit of fluid highlighting it. But this is a uterosacral ligament that really is quite thin here, traveling backwards, but again, quite normal. Now, if this one didn't have any fluid in the pelvis and it's pushed up against the peritoneal surface, it's very tricky to see. But if you do get into the habit of practicing the technique, and you do know that moving out to the side and rotating the probe about 30 degrees will get you into the plane, you can then fan through that area, and you can be very confident that you've scanned through the uterosacral ligament, and you will start to see the little hypoechoic nodules of endometriosis that occur in there. Now, if the uterus is retroverted, again, we need to think about spatial awareness, and the technique changes a little bit because we're already in the posterior vaginal fornix, but it's really not that different. It's, again, just sort of angling out a little bit, and there's that uterosacral ligament coming in through there. And when we push up against the peritoneal surface, we can see it looks very, very similar. So the thinner end towards the posterior cervix, and then thicker as it moves posteriorly. So again, these are some more examples. So again, that thinner end down towards the insertion at the back of the cervix, getting thicker as it moves posteriorly. This is a slightly thinner one, but same again. And we'll see that we're on that sort of as well. Now, one of the things, again, if with a retroverted uterus, I actually found it a little bit easier to see the uterosacral ligaments, because if you can't find them, the uterus is right there and you're scanning from the posterior vaginal fornix. So as you come through the uterus, in this case, we're coming into the uterosacral ligament here. So really just sort of scanning through that uterus in the mid-sagittal section, and then going out past the side will usually incorporate the uterosacral ligament. So even if you don't feel confident that you've definitely got the anatomy and you're absolutely on it, you know that you're scanning through that area, and you are going to see the nodules of endometriosis, so long as you're looking in this sort of area. When we see nodules within the uterosacral ligament, they look something like this. So they can be quite sort of neat little hypoechoic nodules, or they can start to be quite big infiltrating nodules like this one here, which originated within the right uterosacral ligament, but as you can see, has invaded into the vaginal wall. It's adhered to the back of the uterus, and it's also adherent to the rectum. If you're not performing your own scans, you're performing them for somebody else, really describing what anatomy is affected is very, very vital to that surgical planning step. This is another example of a uterosacral ligament nodule. In this case, this is the uterosacral ligament, and you can see that this is starting to sort of protrude off the side, and it's starting to invade into the parametrium. So it is helpful to try and appreciate the anatomy of the uterosacral ligaments to understand when there may be parametrial invasion. Large uterosacral ligament nodules do tend to have a high tendency to invade into the posterior parametrium. And so when we see those on ultrasound, it should be a big red flag. The use of color Doppler isn't terribly helpful in endometriosis nodules, because they typically are poorly vascularized, as most of us know, so they don't tend to show color flow, but it can be a very helpful tool to try and differentiate a very small nodule from some of the vessels that can occur in the posterior compartment, and particularly around the parametrial area. So So it can be very Doppler on, and it can really help you differentiate that. This here is another little example of a uterosacral ligament nodule up against the ovary. So often if we look at the ovaries in a transverse plane, we end up pushing them up against the uterosacral ligaments. And so we'll see nodules in this sort of area next to an ovary. This is another example. This is a right ovary, and just looking at it in that transverse plane, and there's a nodule of endometriosis within that right uterosacral ligament. This one's within the torus uterinus. So in this case, all that had to happen was the probe went straight into the posterior fornix, and this is right in front of us. And in this case, this is adherent to the vaginal wall and also to the rectum. Now, I very much advocate for scanning from the posterior vaginal fornix, particularly to look at the uterosacral ligaments, but we can see them from the anterior vaginal fornix, and sometimes it will give us a bit of a clue when we're looking just at the mid-sagittal section of the uterus. So in this case, we can see there's something going on down here. So as soon as I put the probe in, I could see there was something there, but didn't quite know the extent of it. But the beauty of scanning from the posterior vaginal fornix is this is that same area, and we can see much more clearly there's definitely some pretty significant endometriosis down here. And when we push, the rectum is clearly adherent to it. So it gives us all that information we want to know for surgical planning. To really learn a lot more about the uterosacral ligaments and some of the technique, I highly recommend downloading this paper. This is also free to download by Matthew Leonardi and George Condis. This has a very clear explanation of basically what I've explained, moving to the side and rotating to look at the uterosacral ligaments sonographically. It's also got some very helpful schematic diagrams and descriptions of disease as well. So well worth a read if you're wanting to learn a little bit more about that. The third area that I think is really important from a technique point of view is assessing the rectosigmoid colon. And the reason for this is purely from that surgical planning piece, where obviously rectosigmoid disease really creates quite a challenge and potentially brings in the need for a colorectal surgeon to fully excise. So this picture here is from the IDEA consensus, and this just describes some of the different shapes and ways in which endometriosis can appear on ultrasound when it's infiltrating the bowel. I think from speaking to my colorectal colleagues, they don't necessarily find all the descriptors that helpful, but some of the advanced laparoscopic surgeons do seem to like this pulling sleeve descriptor, where it suggests that the bowel is just pulled in rather than there being a discrete nodule, because they feel quite confident removing that without the involvement of the colorectal teams. But you can talk to your colleagues about what they would like to do to get a good understanding of how you should be reporting your disease. These are a couple of examples of disease on ultrasound. So it's really important to appreciate the normal bowel wall. And typically what we'll see is the anterior rectal wall, and we'll see the muscularis layer very easily. We can differentiate all the layers if we look carefully, but the muscularis layer is the hypoechoic layer that will be very eye-catching. And it will often look nice and thin, and then suddenly it will start to thicken out, and there'll be a nodule like this when it's affected by endometriosis. Here is another one that's a little bit more spiky looking because they can have a various appearance of shapes and sizes, as you saw from the last slide. This is that one we saw before that was attached to the back of the uterus. I think something like 80% of bowel nodules will cause an obliteration of the pouch that we see on ultrasound. So extremely helpful to look in this sort of sliding area. And in this case, we can see this has a lot of retraction. It's got that very, very spiky appearance to it. And here is another one. This one really nicely shows the appearance of the bowel wall. I might just pause this one and drag through it. So again, we've got the muscularis of the rectum here. We've got a little bit of hyperechoic tissue behind, which is just the content of the bowel. And it's all lovely and thin. And then suddenly we get this really fusiform thickening. In this example, we can see quite nicely, this is entirely within the muscularis. And this hyperechoic line here, and then this hypoechoic line here is the mucosa and the submucosa, and we can see that it's not affected at all. So typically endometriosis will be completely confined to that muscularis layer there. In this example, as well as we come through, we can see that there's a nodule of endometriosis within this uterosacral ligament as well, which is adherent to this, and very, very helpful to be able to map all of that out together. And in this case, there was just a tiny little bit of adhesion between these two. So the rest of the patch of Douglas was okay, but it was just this one spot here that was causing a small obliteration. So my third tip to mastering an endometriosis scan is to practice and practice and practice. So once you sort of have a theoretical understanding of how to do techniques, just try and do it as often as you can, because it's like any skill. It doesn't matter whether it's performing surgery, performing an ultrasound, playing the piano, you need to practice at it, and that's how you get much better. My fourth tip I call get better, and that's getting all those kind of tools that you need to really get feedback and learn from your own mistakes, I suppose. And one of the things that's really helpful to have is mentors, but then probably one of the most difficult things to get is mentors as well, because it's very hard to find people to work with, either in clinical practice or even to go and spend some time with other people who really know what they're doing and can help you. But I think you can get quite creative with this. And, you know, we are in quite a connected world these days. You can find people on the internet even who are quite skilled at this, you know, text them pictures of what you're seeing, get some feedback that way. You can really get quite creative with it. I think getting feedback on your work is extremely important. And if you are a surgeon and you're wanting to learn to scan, it's really helpful to scan your own patients in the operating theatre. So you can take your machine into the operating theatre and you can scan them just before you do surgery. And that way you can try and match what you're seeing on the scan with what you see at surgery. If you're very comfortable with the surgical appearances, over time you'll start to use that to feed back to yourself to get better at scanning. If you are not a surgeon, then getting feedback from your surgical colleagues is very helpful, and getting surgical reports to really map back to your ultrasound is very helpful. I think if you do multidisciplinary team meetings and discuss cases where you can get your imaging professionals and your surgical teams together, that's really helpful to help everyone learn. And I work quite remotely from surgical teams normally, so I find sometimes the best way to get feedback is to ask my patients, and I try and find out from them what happens at surgery to them. And a lot are very, very willing to give feedback, and many send me their surgical pictures and things, and it's really lovely. Another really good way to help improve your skills and get better is to teach people. And so either teaching your colleagues or even just trying to explain your scan to your patients is really helpful. It gives you quite a bit of accountability when you're trying to explain to your patients what you're seeing and what your normal anatomy is that you're trying to point out on a scan. I also strongly recommend that you try and do some retrospective review, because when you can look back on your pictures, if you get surgical feedback and whatnot, you can sometimes then retrospectively see disease that you may not have been able to appreciate the first time around while you're still learning. And so a really helpful way to do this is to store some cine clips. And in my practice, we find that we store some fairly standardized clips. So a longitudinal view of the uterus and a transverse view of the uterus, where you try and just encompass that sort of retrocervical area particularly. We take clips of the sliding sign, and then we also just take a clip of the posterior compartment, sort of from left to right, with the probe in the posterior fornix, and of course any pathology that we encounter. And so this is an example of that. So this is a retroverted uterus, just scanning through the uterus with the probe in the posterior fornix in this case. And in this case, from this one sweep, we can almost see everything that is happening in this person's pelvis. So I'll just slow it down for you, and just starting at the right side and coming across. So we've got a fairly typical looking ovary, but we've got a large nodule of endometriosis within the uterosacral ligament there. And then coming across some more, we've got a large deposit of external adenomyosis on the back of the uterus. Coming across some more, we've got a little endometrioma starting to come in off the ovary. We've got a nodule of endometriosis coming into view within the left uterosacral ligament. There we go. We've got a large endometrioma coming through. And I think we even had something else in the uterosacral ligament, it looked like maybe in here. And so by taking these sorts of standardized clips, we can go through this multiple times offline. We can look at it when we have surgical reports, and we can really start to try and retrospectively pick disease, which can help us to cement our learning. Same thing in the transverse plane here. So this is just coming through the uterus, coming down towards the cervix. And again, we can see in this one sweep, if I just take it back here, so uterus looks pretty unexciting, but we can see there's a rectal nodule over here. We can see there is another rectal nodule over here, and we can see that there's some disease within the right uterosacral ligament as well over here. So again, just from that one standardized clip, we can go back and we can find that disease retrospectively. This is an example of the vaginal fornix with retroverted uterus. And in this case, just coming across, we can see there's quite a lot of adhesion. There's rectum being pulled in. There was this other sort of structure here, which is small bowel in this case, which is also being pulled in between the rectum and the uterus. There's another nodule of endometriosis down here coming off the posterior vaginal wall and the uterosacral ligaments. So again, we can get a lot of information from that retrospective review of the clips. This is a sliding sign. And so in this case, this is a negative sliding sign. The patch of Douglas is obliterated, but it's a lovely way to appreciate that there's a nodule of endometriosis within the anterior rectal wall as well. My sixth tip for you is to read, and read a lot. There are some really excellent publications out there now on endometriosis on ultrasound. These are three that I think are particularly helpful. The two how-to guides, they're both free to download. They basically say the same thing, but in two different ways. And they both, again, have great pictures. And this paper on endometriomas and their ultrasound characteristics is quite an interesting read from the white paper. Endometriomas typically have that unilocular ground glass appearance, but this paper sort of investigated the fact that only about 50% of the time they have that appearance. The other 50% have a more atypical appearance, but it is well worth the read. It will really up your confidence in detecting endometriomas. I think it's always worth mentioning adenomyosis as well when we're talking about endometriosis, and these two papers are definitely worthwhile reads when it comes to looking at adenomyosis sonographically and characterizing that. They are also both free to download. The Australasian Society for Ultrasound and Medicine also have this worksheet that you can use when you're performing an ultrasound for endometriosis. It's a bit of a checklist of structures, and you can document down the disease you're seeing as you go, and that's free to download as well from their website. And that can be quite helpful as a bit of a tool to have with you when you're scanning, as a bit of a checklist of all the structures that you need to scan through. And obviously, as I mentioned, there's a lot of technique to go through, which I haven't really gone through tonight in a lot of detail, but there is a lot of ways that you can see that. There's some excellent content on YouTube. These three channels are my favorite: Gynecology, Ultrasound, City Imaging, and Dr. Matthew Leonardi's channel. And Dr. Sophie Pearson from Melbourne has a fantastic website that she's put together, Endosonography 101. And she's got some fantastic lectures and videos on that. And I particularly recommend a video that she has on the spatial awareness of the anatomy. She has excellent graphics in that. And it's a really helpful one to really get your head around how all the anatomy looks sonographically. Now, was there any questions that had come up before we move on to any cases?
You can continue, Alison. We'll ask questions.
I'll keep going. Yeah, excellent. So I've just got a couple of cases here that I thought were quite interesting. So this first one was a 37-year-old woman. She had a known history of extensive endometriosis, and she was hoping for a pregnancy. She had undergone multiple failed cycles of IVF, so she was planning to undergo surgery. And she actually just came in her fertility specialist sent her in because they'd noticed hemorrhagic cysts and weren't sure about doing another egg collection, but she actually just wanted the surgical planning, really. So we can see she has retroverted uterus with a marina in it. It's a little bit messy looking along the back of her uterus here, so that sort of raises suspicion for some external adenomyosis. She has an endometrioma on the right side. I think she has a second one in there as well. The left ovary didn't look too bad, though. We then tested ovarian mobility, and the right side looked to be a little bit tethered, and the left side didn't move too badly away from the uterus, but we weren't so sure about the side wall. And then in the posterior fornix, so she has some disease in here. You can see some uterosacral ligament. I'll just play that again. It's a bit hard to appreciate, but there's just one little part of this rectum that seems to be getting pulled. Sorry, we'll need to pause it, and it's very subtle. There we are. So there's just a little bit of what looks like a bit of tethering, but there didn't look to be any discrete bowel nodule at all. So that was her rectum. So didn't look to have any nodules through it, and there was nodules through the uterosacral ligaments. So the summary for ultrasound, that was obviously just a few pictures from it because it was quite a detailed scan. She had this sort of anteverted and retroflexed uterus. She had adenomyosis and some endometriomas around the place, uterosacral ligament nodules, adhesion of the ovaries and rectum that seemed to be adhered, but with no rectal nodule, so it was causing a partial obliteration on the left. These are her surgical pictures. I'm not a surgeon, so I try not to talk through surgical pictures too much because I make a fool of myself, but we can see that there is that obliteration on the left that we had noticed. They went through and did a full excision for her. And at surgery, they basically found stage 4 endometriosis. With most of what we had seen at ultrasound, we didn't see the superficial disease in the anterior compartment, though. But everything mostly matched. The surgeons with the colorectal team were there, and they weren't sure if there was a nodule or not. So they basically decided to just do a small disc resection in the area that they were worried about, but it came back histologically negative, which was positive for her. But basically, we found all of that prior to surgery, and she was able to be triage to the right team. They got the colorectal team there, and nothing was overlooked at her surgery. So really good outcome. And she went on to have a baby, which was lovely. Case 2 was a 29-year-old female. She had long-standing pelvic pain, and she'd been trying to conceive for 7 months. So we've already seen her clip before, actually. So this is that same person that we looked at before, sweeping through the uterus. So this one doesn't show quite so much of the posterior compartment, but she has this large deposit of external adenomyosis, uterosacral ligament nodules on the left and on the right, and endometriomas. Here we go. There's that posterior compartment that shows the ovaries a little bit more clearly. So it looks like 2 endometriomas on the left ovary. She also had this fluid deposit, which we thought was probably a hydrosalpinx on the left here, but the right ovary didn't look too bad. And she had nodules throughout her posterior compartment as well. But her rectum didn't actually appear to be involved. There didn't appear to be a rectal nodule, which was really good. So ultrasound findings, she had external adenomyosis, 2 endometriomas, a hydrosalpinx, lots of nodules on the uterosacral ligaments. The left ovary was adherent to the uterus and the uterosacral ligaments, and her pouch plug was obliterated, but there was no rectal nodules, which was good. And so if we use the Enzian classification, again, to sort of map for surgery, we know with this she's got stage 4 disease. When it's really bad, it's fairly easy to say that. But we can use those Enzian classifications, and we obviously don't know about the peritoneal disease because we don't see that so readily on ultrasound. But we do know that within the ovary, she's got the endometriomas, so we can map those out. With the hydrosalpinx, we know that the tube is going to be obstructed, so we can map that, although we don't know what's happening on the right. And we can map out the deep disease properly and give a far location of adenomyosis as well.
Alison, can I ask?
Yeah.
The previous slide.
Yes.
So in this ovarian, you have mentioned it like this. Can you please explain this?
Sorry, what was that?
The ovarian lesion in #Enzian classification, you have written /2R/0. So usually we write left on the left side of the slash and right on the right side. So I didn't understand much, so I just want to know.
Oh, sorry. I just wrote that as left is a 2 and right is a 0. So
okay.
Does that make sense?
Okay,
yeah.
fine.
Sorry.
Usually we don't write left and right. I got confused. Sorry. So I got it now. So left is 2 and right is 0, you're saying?
Yes, left was 2 because she had endometriomas with
2/0. So it is like self-explanatory that 2 is the left and 0 is right.
Oh, that makes more sense, doesn't it? Sorry.
So the 21 paper #Enzian conveys it like that. That's the reason I asked it.
Right. So, yep. So my third case is a 50-year-old woman. She had, surprisingly, 47 years of her life not complained about too much. Then she experienced 3 years of increasing dysmenorrhea and menorrhagia, and she'd had adenomyosis diagnosed on another ultrasound, but she had just gone to the point where she was pretty sick of it and decided she wanted a hysterectomy. So we were scanning for hysterectomy planning. And so this is her uterus. She's got a lovely anteverted uterus. But again, with that sort of clip through the uterus, we do get a lot of information if we look carefully. So the first thing that I draw my eye to is the position of the ovaries. So the ovaries are both sitting quite low. And then if I pause it, I've lost my little, here we go. So if we just slowly look through, if we get to about here, we can see if we look in that area posterior to the cervix, we can see that there's something that looks like a nodule of endometriosis, and the bowel looks like there might be a nodule through there as well. So moving along, she too has endometriomas on the right and a small one on the left as well. And again, the anatomy of the ovary doesn't quite look right. It looks like it's sort of pulled in, and it looks like there's this nodule sitting down in the retrocervical area. So when we test the ovarian mobility, the ovary is not moving on the left. It is pulled in on the right, and it's adherent to the this nodule within the uterosacral ligament. And then scanning through the posterior compartment. So again, we can see there's a lot of endometriosis down there, but it takes a little bit of thinking to map it out. So we'll just slow it down nice and slow. So this is with the probe in the posterior compartment. We can see the bowel is pulling into this area at around the torus uterine, and that seems to be going off into the left uterosacral ligament. So there's a little bit of a nodule down in here. Then as we come back and through, there's also it was hard to actually get into the fully into the posterior fornix, and that's because she's got a vaginal nodule, this lady, which is quite isoechoic. They're very hard to see, vaginal nodules, often sonographically, but you often will feel them. So it's you'll sort of scan through the posterior compartment, and it feels like you're going over a bump, or your probe will sort of come out a little bit. And when you focus on in, they've got these little nodules down in here. And again, she had another little nodule over on the right side. So in this case, this lady had adenomyosis, she had a vaginal nodule, she had a large torus nodule that extended into the left and the right uterosacral ligaments. She had another uterosacral ligament nodule on the right, a rectal nodule, which was adherent to the uterus, causing a pouch of Douglas obliteration. But her anterior compartment looked okay on ultrasound, and her parametrium was unaffected sonographically. So again, we classify this as stage 4 disease, and using the enzyme classifications, again, we don't really know what's happening with peritoneal disease, but in this case, she gets a 1 for each ovary. The tubes, we don't know, unfortunately, if they're patent or not, just from this scan, but we can map out and score that deep endometriosis and give a score for adenomyosis as well. So that's all I had prepared for you. So like I said, please reach out to me online if you wanted to know anything. And I'm doing a little bit of research at the moment. So if you wanted to take part in a survey that we're doing, then please do. We're trying to learn a little bit more about how people are learning to perform endometriosis ultrasounds and how artificial intelligence might help. But I'm more than happy to take any questions as well that people have.
Fantastic talk, Alison, and fantastic key points how to learn ultrasound. So we have 2 sonologists with us. I would like to take their inputs as well, how one can become an expert in doing ultrasound for endometriosis. So Dr. Raju, would you like to share your inputs as well? Dr. Raju, are you there? Dr. Madhavi, are you there?
Hello, ma'am. Hello.
Yeah. So Dr. Raju.
Sorry. Can you hear me, ma'am?
Yes, we can hear you.
Thank you, ma'am. Thank you for the wonderful opportunity, ma'am, and this wonderful webinar. Thank you, Alison, for sharing your beautiful insights. Lot to learn from you. I've been learning. My first take would be because I come from a low research setting here. Majority of we gynecologists do our scans, that is TVS, of course, what we are dealing here today. I want to tell you about is it should be a dynamic scan. It's not a static scan. So madam has already showed about the importance. The most important one, I would like to tell everyone that we have to do the sliding sign. The sliding signs are the most important ones. And without that, you cannot report any transvaginal sonography, especially for an infertility lady. I have some few questions to Alison before I could put up my few takes on my scans that I do. Which is the best time on which phase of cycle do you really think that you're going to span across these pathologies, or is it not phase related? And another is, do you routinely prepare the bowel for looking into these, especially the uterocircles and the bowel nodules, which will stand out? And your experience in the sonopodography, if what I have learned from, I'm not doing, but known from Leonardo. Any takes on this, ma'am?
Yeah, so in terms of phase of cycle, we don't routinely look at a specific phase, and we sort of tie it to what our patients need. So in the fertility cohort, we typically are scanning in that very early phase of the cycle to be able to assess follicles properly. And so rather than submit people to 2 scans, we just do it all in the one. I do find I don't perform any sonopodography. So for those that aren't familiar with that technique, that's a technique that's been shown within literature to try and diagnose superficial endometriosis. So basically by placing a catheter into the uterus and then infusing saline into the pouch of Douglas via the tubes, you can fill the pouch of Douglas with fluid which distends it slightly, and you can then see superficial disease projecting on the peritoneal. I do find that if you scan in the second half of the cycle, often after people have ovulated, they're going to have some fluid in the pouch of Douglas physiologically, and you can sort of get that effect anyway. And it can be quite helpful to have that little bit of fluid to help demarcate the uterosacral ligaments and that sort of thing as well. So, so I do probably prefer to scan in the second half of the cycle if possible, but it depends on what our patients can do and what else they need. So that's my take on that. The other thing I would say with podography is when we do sort of do it, we don't do it formally, but we do some hycoses for looking at tubal patency, again, with our fertility cohorts. And in our practice, we use agitated saline rather than using foam contrast or anything like that. And the agitated saline you need to be quite quick with to look through the tubes. It doesn't stay bubbly for very long, but it does settle in the pouch of Douglas and then give you that distension, and you can have a good look for nodules within the pouch of Douglas. So we always have a look after we've done hycoses as well. In terms of bowel preparation, we don't routinely bowel prep. I think we used to, and we stopped for a few reasons. Mostly we were finding it wasn't that helpful. I think when we were less good at scanning, we probably found the bowel prep a little bit more helpful to help highlight the bowel more clearly. But as we've gotten better and better at scanning, we certainly don't need it. I think also from a patient point of view, it wasn't particularly pleasant to be doing the bowel preps. And then sometimes people wouldn't time them properly and they'd end up just very uncomfortable for scans. And so we found it was a little bit problematic. So we don't routinely bowel prep. But I think it's a personal preference thing as to if you wanted to. But again, literature doesn't show that it's that helpful.
Thank you, ma'am. Some few takes on the because I work with an endoscopy surgeon, because of whom I have been learning a lot. So it is a teamwork, especially I can even assure that even Madhavi ma'am is working with her. So we have better audit, like when I do the scan, I do the reporting, then I have retrospective learning that what I have missed in the OT. So what are the important things that we are missing out? As today, madam has emphasized a lot on looking at our uterosacrals. This is one area that we need to improvise, that we are doing it now, where we place the probe in the posterior fornix and try to span across the right and the left uterosacrals. Ma'am told it is around 30 degrees. Yes, if you're looking on the right uterosacral, you have to turn your probe clockwise. If you're for the left uterosacral, you have to turn your probe anti-clockwise so that you're going to span it. So in this way, yes, you in the mid-cycle does help it most of the times. Otherwise, uterosacrals without any fluid, you can definitely trace. one of the most important signs what we are seeing of late is that we have done a normal case where we see that there is no endometrioma, the sliding signs are okay with the ovaries and the posterior bowel, but you are finding some uterosacral nodules, which are the most common sites. And in laparoscopy also, I want to tell you, sometimes these uterosacrals look normal, but they are stout enough. But your imaging is good enough to say there is a uterosacral nodule in the rectovaginal space. Yes, you can dissect that and you can remove that. So that is how our transvaginal sonography is definitely helping in making this as meticulous. Some more points I want to add, because everybody will be doing about, Madam has emphasized about looking of endometriomas and slidings are very easy. One thing I want to add is optimization of your images play a very important role. That was seen in our Madam's screen, where if you want to look for a bowel nodule, the area of interest has to be there, almost covering your more than 60 or 70%. You just can't span the uterus being on the top of the screen, and then you cannot make out these nodules. And I still feel when you have a very good machine like this, you should sit with an application engineer so that you will be able to see this uterus standing out properly against the bowel, against the uterosacrals. These things will really help us in optimization of our images. I have one more suggestion, like when you are looking at the uterosacral nodules, I sometimes use the 4D application where you can, with volume contrast imaging, these nodules stand out much better, and the dimensions also are much well defined. I want to ask Alison, ma'am, how is that you are going to report the nodules if you see it on the bowel or on the uterosacral nodules on the 3 planes I know? And how is that going to help the surgeon? This might be take for Vimi ma'am also. What is that you want from us that you are going to decide it's going to be a bowel shaving or you're going to sigmoid resection and all? So what is that you want exactly from us in what parameters in which plane? So you can take on that.
Dr. Chinjini, would you like to answer this as a surgeon, what we look for?
Yeah. So thank you, Alison, for that wonderful talk. Basically, the areas of difficulty in surgery are predominantly two. More than the bowel, it is the parametra, which I actually in my practice find it difficult because it's very underreported. And so till the uterosacral is fine because the dissection is pretty easy. But once the disease grows along the so-called cardinal ligament or along the uterine artery and laterally, it is then when it starts encasing the ureter. So this is one area which is often underreported when we do the transvaginal kind of, the Enzian B, so to say. So this is one area on how can you improve your diagnostics there, and you turn your probe 30 to 45 degree, you reach the uterosacral. Do you go beyond that in order to find the uterine artery by a color flow or something? So by which you can increase the reporting of that compartment. With regards to the bowel, at least I as an excisional surgeon am not facing a great deal of trouble, because when we get the reporting on the routine zone, which is around, let's say, 9 to 11 centimeters from the anal verge, these reportings are pretty accurate in terms of circumference of involvement, depth of involvement, and the length of involvement, which helps us decide between shaving versus disc versus segmental. With the far-off lesions, let's say, which is beyond 12 to 13 centimeters from the anal verge, sometimes there is difficulty. With the good sonologist who can probably through a transvaginal ultrasound detect as far as almost 17, 18 centimeters from the anal verge, it's okay, but that's the limitation, especially when we have skip lesions. So these are the two areas. If anyone can troubleshoot, it is fine. I would like you to enhance on this.
Yeah, exactly, ma'am. We do have limitations especially in TVS. So we cannot pass above the pelvic brim, definitely. Though we have to reduce the frequency to see the far off places, but our imaging optimization is not good. So more of in the pelvis or up to maybe up to the body of the uterus, upper body, we can definitely span across and get these lesions properly. That hysteroscope, actually the word is a misnomer, where we start doing our hysteroscope from the introitus, but as a transvaginal sonographer, we have to begin it from introitus, as what madam has showed. So we are missing some lesions in the vaginal plate. And also when we start tracing the bowel, we have to do it. I have seen Madhavi madam showing this in one of the conferences, where we start seeing from the anal sphincters. Then we walk along the rectum. The layers of rectums are well defined. Then we start proceeding ahead. Gradually, we try to see from where exactly and what centimeter it has been located. This is really helping us. So it has to be a TVS. It should not be just going hitting the cervix or the anterior fornix and then spanning across is not the sonography that we have to do or the reporting. And one more thing I want to tell, maybe many would have been following various classification, even NZN is a very good enough, but peritoneum is one part which I'm really missing it out. Whatever you do, I feel instead of putting it on words, I like putting it in diagrams. So I draw the uterosacrals, I draw the uterus, I draw the anterior compartments with the bladder and the ovaries. And if you see a hydrosalpinx, so I feel that would give a more picturesque data for the surgeon, what exactly is dealing with. Even a bowel nodule, if it is such a big, large enough, measure that and give it in dimensions and how far it is from the introitus. So in that way, I just want to add on these things. Maybe Madhavi ma'am will add more in the reporting formats.
Dr. Madhavi, are you there? Okay, till she joins us. For a parametrial endometriosis, definitely transvaginal scan cannot predict everything. So there are some indirect markers which should give you a prediction for parametrial endometriosis, and you should suspect, like presence of diffuse adenomyosis, presence of hydronephrosis, ovary fixed to the lateral pelvic wall, and absence of sliding sign. So these are the signs, and this has also been reported in a parametrendo study by Ceccaroni group. And they have found a very good sensitivity and specificity for these markers. If they are present, then you should suspect a parametrial endometriosis, especially in presence of hydronephrosis. So that B compartment, which Dr. Shinjini was mentioning, which is mediolateral compartment, is little difficult to assess beyond the uterosacral ligaments on transvaginal sonography.
Yeah, we do.
Then we should look for the indirect signs, and we should expect that during surgery, what difficulties we may face, we might have to do a nerve sparing surgery or counseling the patient for the ureteric endometriosis or ureteric reimplantations as well.
So this is for Madhavi, madam. In case, do you give importance to the size of the uterosacral nodule that you see in predicting parametrial endometriosis? Is there a criteria in which you start suspecting if the USL nodule is large?
Hello. Thank you all. Thank you. It was wonderful lecture and very insightful. To sum it up, if take-home points, if you have to focus, it is know the anatomy, know the technique, and very important, know the clinical indication, which can strategize the extent of a scan. That's it. If you have to understand. And the latest from today's webinar, what I learned is, I think the best way is to give cine clips in a pen drive to the patient where the surgeon can view themselves. That is a better way of interactive imaging platform. I think this is the point which today I learned from this webinar, retrospective review. And coming to the anatomical detail, the most important, which I learned, uterosacral ligament is the most difficult area. But it was Dr. Sophie Peasons who came to India, and she told that it is very difficult anatomy, the 30 degrees, especially when the anatomy is distorted. It is really difficult to point out where the uterosacral ligament is if there is no fluid within. Second most important point I would like to emphasize is genital organs are not standalone structures. The ligaments and connective tissues which are holding the genital organs in a compartmental fashion in the pelvis, they are the difficult things which are involved. Uterosacral ligament per se might be difficult as a novice to start with, but the landmark to identify uterosacral ligament is internal os of a cervix in a transvaginal scan. I think to start with, everybody who is doing a transvaginal scan, first thing which we should understand is go beyond the standard pelvic organ examination of AIUM guidelines and extend it to compartmental fashion. In this manner, posterior compartment, statistically, it is most commonly involved. The uterosacral landmark, it is internal os. So at that point, the torus, as we have seen, it is involved, irregular. At that point, if you orthogonally twist, the other indirect signs we would see: kissing ovaries, medialized adherent ovary, the rectum pulled up. Depending on the extent of inflammatory lesions, it becomes sometimes very difficult to delineate individual uterosacral ligament anatomy. In that condition, it is a frozen pelvis in which the uterosacrals are deeply involved in the adhesions. So in that condition, it is very difficult to measure the nodule in isolation. This is what I personally feel. So I do not measure the uterosacral ligament nodules if it is dense frozen pelvis. But to start with, based on the clinical indication, and once you start doing the scan from the perineum into the fornix, external os, internal os anatomy should be torused. Is it clear? On orthogonal twisting of the probe, the most inferior at the level of external os, the sectional plane which you see would be the vaginal reflection. And if there is no vaginal nodule, you can slide your probe easily into the posterior fornix. But if there is a nodule in the vagina, the patient will be very tender. She will not allow you to do a probe insertion into the vaginal fornix. So the dynamic assessment, once you start interacting with the patient, you will get to know many clues. But the most important thing is knowledge of the anatomy going beyond the routine pelvic organ anatomy into the ligamentous attachments. Like, for example, if you have to look the anatomy of a parametrium from a surgical point of view. So we are looking at two things: the uterine arteries entering at the level of the cervix and the ureters crossing underneath the uterine vessels. I think these are the two things which any surgeon would be interested in knowing, right? So once you put the probe orthogonally at the level of the internal os, at the level of the cervix, you will beautifully see the parametrium as vessels, uterine vessels crossing it. If it is very clear, there is no soft tissue, irregularity, puckering, very unlikely that the parametrium is involved. So such are the clues which you can direct to the presence of involvement. Wherever there is involvement, the clarity of the fat between the structures would be lost and the secondary signs would be seen. I think more and more you will understand if you get an eye of a normal anatomy first. First thing is 20 normal pelvic organs. How do you look beyond the normal sagittal plane of the uterus? Once you have understood, familiar with the normal uterus cross-section, myometrium, endometrium, now go beyond the organ. Trace the uterine peritoneal reflection. Here, I would like to ask a question to Alison. Usually, peritoneal involvement is very difficult to comment on ultrasound. But in NCN, they say P1, P2, P3, based on the extent of peritoneal involvement, P3 more than 7. My personal observation is when you do a good transvaginal ultrasound, once you start with a compartmental analysis, the vesico-uterine fold of the peritoneum is seen as a thin, bright reflection, very clean, smoothly outlined, against which you demonstrate the sliding signs, both anterior and posterior. Now, when you're not able to demonstrate this clear hyperechoic line bordering the uterine myometrium along the serosal aspect, can we not take it as a peritoneal involvement? That would be my take. And secondly, in NCN classification, FA, adenomyosis, that's it. They won't characterize it with, here I apply the Musa criteria of adenomyosis in my report. I categorize the extent of adenomyosis involvement with respect to the volume of the uterus involved, which will enable the surgeon to plan the surgery and prognosticate and counsel.
Yes, I think to answer your question about the if the peritoneal surface is not smooth,
Yes.
I think there is a few things. I think if we're looking at surgical planning, then I don't hesitate too much to agree with that. I think I deal with a lot of primary care patients as well, though, where the algorithm is very much that diagnostic. They just want to know what's causing their pain. I think we have to be very careful in that group not to have false positives, because I think we don't want to be potentially sending people on for surgeries that they don't need and exposing them to risk if that is not their problem. So in that group, I'm a lot more conservative with what I'm willing to say. And I think the other consideration is if people have had a previous surgery, we need to be very careful because there'll be some peritoneal scan from previous and and again, I don't think it's helpful for patient counselling if we give them incorrect information. But certainly, I think if we've got somebody that, you know, we're sort of planning for surgery and we see just that, I sort of call it a moth-eaten look. It just looks messy and not smooth. I agree. I think that you can be fairly confident there's going to be some disease there, and the little you get a lot of hypoechoic little foci across the peritoneum, which
Yes.
is almost certainly that superficial disease.
Those are the cases. Yeah, so that is how I try to correlate, because a normal pelvic ultrasound, in a normal pelvic ultrasound, you can trace the neat peritoneal. I agree with you. In cases of previous surgical things, adhesion things, we write PX. That is, it is a surgical correlate. But
Yeah.
if a person primarily is undergoing pelvic endometriosis surgery with the findings of these, like medialized kissing ovaries, ill definition of the peritoneal reflection from fundus all belong the posterior surface, that itself is classified as P3, isn't it? More than 7 centimeters, puckering, involvement. So this I wanted to ask the Enzian people who are writing the Enzians.
But I still feel we underreport if we start on P, ma'am, because we cannot totally assess the peritoneum in TVS.
Correct. Correct. Not.
Yeah. It is going to be comprehensive report, maybe post-operative or intraoperative. They are going to tell us better definition of those.
So actually, P is pelvis as well as beyond the pelvis. So it is not possible to do it on sonography. So, and even this question I asked Dr. Keckstein also, because whole of the posterior peritoneum is involved in inflammation and adhesions in the surgery on frozen pelvis cases. But what, by definition and as per their paper, it's the superficial lesions which we may found on the pelvis peritoneum as well as beyond the pelvis. It may be upper abdomen or anywhere in the abdominal or peritoneal cavity. So
it is the superficial lesions.
These are the superficial lesions. It does not involve the peritoneal puckering and all that. It's the superficial lesions less than 5 millimeter in depth. The total diameter of that, and this is in the pelvis and beyond the pelvic brim both. So anyways, on ultrasound, it is not possible for us to see beyond the pelvis, right? So it has to be.
It is PX.
It has to be surgical correlation. Then only we can justify the P.
Yeah.
So as such, they have, by definition, by their paper, they have not mentioned it as a peritoneal puckering or the inflamed peritoneum is not included. It's the superficial lesions less than 5 millimeter in depth.
The inflamed peritoneum is very difficult to
then all stage 3 and stage 4 will be P3.
We cannot pick
yeah, because see, so many times there is a intraperitoneal spill in the case of an endometrioma. When you go inside and when you put your scope in, there is this chocolate spattering all over. In these women, the peritoneum is by default thick all over. What do you categorize them as? What P do you give them? It is very, very difficult for us during surgery to P it. I mean, to give it a P. So this is one of the very, very, for all those who are operating, it is quite common to see, especially in large cysts where they would have undergone some subclinical rupture at some point of time. You will find that the entire anterior posterior peritoneum is spattered. And therein the peritoneum quality is much thicker and you don't really know whether to pee it or not to pee it. So that is...
It's the superficial lesions rather than the peritoneal thickening or the inflammation which should be included.
Yeah.
Very difficult to classify it is on ultrasound or even on MRI. The superficial endometriosis is again still doubtful. Do you agree, Alison?
Yeah, I think to fully classify it, I mean, we can certainly sometimes see lesions, but I think to know the full extent of it on ultrasound is impossible, and MRI as well.
Yeah. So in Enzian, it would always remain PX, isn't it? So from an imaging point of view.
Yeah, if you cannot determine, it will be PX. It will be PX.
So it should be PX, right? Yeah. And what about the focal adenomyosis, FA?
Adenomyosis, they have only given adenomyosis, but in my practice with surgical staging, FA, within brackets, I do write it is diffuse focal or focal adenomyosis of outer myometrium, just for our knowledge and our understanding what kind of adenomyosis we encountered. So,
Madam, if you report according to the Musa criteria, it is much better for the surgeon to be able to handle it, to counsel the patient whether they will do a wedge resection, whether she needs triple flap or more morbid surgery, because adenomyosis is a much more morbid surgery than performing the endometriosis excision surgery.
no, she describes it as like that only. The uterus and
Yes.
the size is this diffuse adenomyosis involving this much percentage of the uterus and all. But
Yes.
he's asking for the writing part of it when we write the
Writing.
clinical NZN. So FA, as per hashtag NZN, they have not sub-classified it. So in clinical practice, we can just write within brackets what kind of adenomyosis it is. Just to give an idea, it can be a junctional zone abnormality, it can be diffuse or focal adenomyosis, so that there is a better understanding. Adenomyosis is a broad term. So I use in surgical this thing. Dr. Madhvi gives a description and she writes FA. She has started writing FA 1, 2, 3, but definitely there is no set definition for 1, 2, 3. So we write F, what type of adenomyosis, for the better understanding and follow-up of the patients as well. And Dr. Madhvi, I would like to ask you, as Alison said, she does not prefer bowel prep for the patients. What is your take on that? Because we routinely prep our patients for bowel prep and then send for scans, right?
See, for diagnostic criteria, ideally, there is no requirement, because if there is a bowel nodule, patient has clinical symptoms of bloating and all, usually you will find bowel nodule. But the ease of scan with bowel preparation and the visibility of pelvis and surrounding thing without thing will make our job easier. So I prefer bowel preparation if the patient has poor bowel habits with terms of constipation or otherwise.
Okay.
So I would prefer.
Okay,
Yes,
I want to ask Madam, if so, when in our practice, when we handle right-sided TO masses, endometriotic TO masses, how often can you diagnose the appendicular involvement? Because we have had problems at times because we've kind of missed out on taking the consent for appendicectomy, and there have been now we are routinely taking for any right-sided TO mass, but how is it that with the ultrasound, what is the sensitivity and how do you go about it?
I think it is difficult, Dr. Shinjini, because once it is a phlegmonous adnexal mass, now the location of appendix itself is variable. So until and unless it is pelvic appendix involved by that, it is very difficult. Patient pain, nature of pain, it is directly pointing to isolated appendix, it is difficult. So when there is a TO mass on a TVS examination, you can go maximum up till the upper limit, where you will see periovarian planes are ill-defined. There will be chocolate cysts, and you will focus on the uterosacral ligaments and the adhesion of the bowel surrounding it. But you will not try to characterize whether it is appendix as per the criteria of blind ending loop, inflamed bowel segment. It is very difficult. I don't think I write as involved appendix until and unless there are definite pointing features. In a TO mass, if the appendix is informed, usually you look for tube. You try to trace from the corner end whether the OV is surrounded by a tubular hydrosalpinx from the medial edge of the uterus to the ovary. So whether there is a hematosalpinx or a tube hydrosalpinx or diseased tube present or not, that much we try to characterize. But appendix as a part of dilated structure, I don't think I have. Beyond that, you go and look for when the parametrium is involved, you try to look for ureter, dilated ureter. That also we cannot see until and unless we take an upper abdomen section and look for hydroureteronephrosis. Appendix commenting, I have never done that.
Yeah, but this becomes a surgeon's problem, because at times the tip of the appendix is completely into the mass, and that is the time when you are really, as this is from a surgical point of view. So just curious to know if probably a transabdominal scan or what is your protocol to?
These are limitations that we have.
Yeah.
So we routinely take appendectomy consent for all patients.
Yeah. Okay.
And in some areas like, retropelvic, when we have sciatic involvement areas and all this, I don't think our USG will help. So we have to go for MRI. Only when we have a lot of, when it might be on the patient's complaints also. So when our patient profile is telling that she's having the a typical pain morphology, then yes, we may have to ask for MRI. Any take on this, ma'am, Alison? These areas where we are not able to span or scan across the deeper pelvic structures.
Oh, yes. Yeah, it is a challenge. I think there's some work that's been proposed about looking at sacral nerve roots and things, which I've been practicing and not mastering very quickly. So I think that it's a real challenge. And I think that you're right. That's where the role of MRI really becomes helpful, is the things beyond the field of view of the ultrasound. The MRI can really assess quite beautifully.
Ma'am, my small take home for all those basic sonologists who are trying to do the sonography, as what Madhvi ma'am has emphasized, that we have to go vaginal sonography. Yes, we have to look for the posterior compartment, try to assess the uterocircles in each and normal cases, then definitely you'll get an abnormal one. That practice really makes us define these lesions better. Sometimes you may not have an endometrioma in the ovaries, but you have this pelvic, the POD lesions, especially the torus and the uterocircles has to be spanned across. And you start doing your TVS from the introitus. You don't like to miss the vaginal nodules also. And the sliding sign, which is the most important thing that we have to do. It's because TVS, I feel it is always a dynamic scan. You just can't look into the structures and come out. You have to slide across all these the structures that we have. And one more is also look for, you be gentle while we are doing these scans and look for any site-specific tendernesses, which can really help us to define. Because what reporting we are going to do as a primary sonologist, it should be so better that she's going to get operated. The primary surgery should be a good one. If it is a real bad endometriosis, you should not miss it. So that is one important area for basic thing to be told in, that is in TVS, that we have to do.
Any other questions we have? So it was really fantastic, Alison, to have you here with us. And the take-home points are really, really good. And as you said, the feedback is very, very important. This is how we have improved, because sometimes if our scans furnish some information and we do surgery and we give feedback to the sonologist, definitely they try to look for it in further scans. So this is how
Yes.
we have also improved over time. I think Dr. Madhvi will agree with us.
Completely.
Over the time, she does a scan and she gives me a call. What did you find in this patient? So immediately I'll tell her, okay, I found this. So she will try to match her findings, and then sometimes she cannot match, then she'll try to do it in the next patient, for atypical cases especially. So this feedback is very, very important, and that connection should be there between the surgeon and the sonologist to improve the surgical care, as well as the reporting of ultrasounds as well, and so that we can plan our surgeries in a better way and we can give the optimal outcomes to our patients. And it was lovely having all of you. And
can I ask one last question,
yes,
Malcolm or Alison, anyone? So basically, just wanted to know if there is a way to detect an ovarian abscess in an endometrioma, because now that a lot of ovum pickup goes on prior to the surgery, sometimes we as surgeons face a lot of difficulty when we encounter a huge ovarian abscess, because this is one time that sometimes, you know, it may be very difficult to save that ovary in case it is a lot of pus inside. Now on the MRI, I have seen when the reporting comes, you do get some hint on the fact that this could be so obviously patient's history is important. She will tell you post pickup there was a turbulent phase, she got readmitted, there was pain, there were raised counts, etc., etc. But some of them are quite cold and silent cases also, and when we operate them, we just enter a bag of pus. So this happens. So is there a way through the, if not this, because this talk is on ultrasound, so is there a way that probably you can diagnose endometrioma converting into an abscess?
It's very tricky. Abscesses can look very similar to endometriomas. And I think that the couple of things that sort of strike me is that you'll get a more inflammatory looking pelvis. It's quite a subtle feature, but it will look far brighter. It's almost like you sort of think, oh, I've got my gain up too high on the machine. And that's that sort of tissue surrounding the ovary will just be so inflamed, it will look like that. And that's one of the sort of key differences between seeing endometriomas and abscesses. Abscesses, while the internal pus won't have blood flow, they usually will have a lot of peripheral blood flow, getting my words out. It's getting late here now. And that can sometimes be another clue, but you're right, it's extremely difficult. And I think even, I mean, some of these post-IVF infections can be subclinical even, so picking them can be just so difficult.
But as you told Dr. Allison, it is correct. It looks very bright. The pelvic peritoneal reflections are very bright. That is one of the signs of infection. That when we subjected all those patients to MRI, then the classic features of penumbra sign, T1 hyperintense pus, those characteristics were seen. So on ultrasound, if you have to take, patient will have disproportionate pancyclical pain post ovum pickup, or the increased echogenicity of the pelvic peritoneal fat surrounding the so-called endometrioma looking. These are features which should prompt us to think that secondary infection should be suspected in the appropriate clinical scenario.
Okay.
Yes.
Yeah.
Okay, I think it's time. It's, I think, past 12 in Australia.
It is. It's past midnight now, so it's time for
the
bed for
passion
me.
that with which Alison is teaching us. And thank you so much, Alison. We are looking forward to have you in India in 2026 for EFA
Yes.
conference.
Yes, I look
She
forward to
had
it.
to come in March, but due to some reason, she could not come and join us. But 2026, she'll definitely join us. Thank you, Dr. Shinjani. Thank you, Dr. Raju. Thank you, Dr. Madhvi, and everyone who could join us. And apologies to those who could not join us because our capacity was full and many people could not join us and they messaged. For them, this will be uploaded on YouTube and they can access it anytime after a few days.
Thank you so much.
Thank you.
Thank you so much.
Thanks, everyone.